Hi, good morning, everybody. My name is Ted Walker, and I am your instructor for Introduction or Overview to Perioperative Nursing. And several of you have asked whether or not I would be giving any lectures for this class. And there are no lectures that are graded. However, I wanted to go ahead and honor some of your wishes and give you a video with each module that maybe can help explain things, can help you get some insight, and not necessarily give you a reference or anything for your assignments, but help you to take the knowledge and to integrate that into how you learn about what perioperative nursing is. So in this assignment for this module, you were looking at doing a patient interview. And I'll be going in and looking at your patient interviews, and I'll be giving feedback on all of your patient interviews and how they appear as normal as they can be, but mainly looking at the questions that you ask, how you ask the questions, and to provide you a little bit of feedback on that. But the key on this assignment was that you really looked at what you had, which were the references in your book primarily, and able to take a checklist, which was there in your book, follow the checklist, and complete a preoperative interview. So over the years, I've developed pretty much a canned script for a preoperative interview when I go in to see a patient. Most people will work off of the electronic health record to complete their checklist and simply run the checklist as a pilot would when they're getting ready to take off in an aircraft. And that's exactly why we build checklists in healthcare the way we do, is to allow us to have highly reliable organizations. When I look at using a checklist, I look at that as making sure that I am documenting what needs to be documented in order to allow that patient to safely enter the operating room. So there are two things that are not only required by federal CMS statute, they're required by the Joint Commission and AAAHC, the accrediting bodies for hospitals and ambulatory surgery centers, but they're also what we absolutely have to have in order to protect our patients. And that is the history and physical and the consent. So when we look at the history and physical from the provider, there are certain requirements that are governed by the medical staff bylaws of the organization. They are looked at by many organizations, from the legal ones that I just mentioned, state organizations, for what their content will be. But the timing is pretty much the same across the nation. And that is that an H&P, or a history and physical, has to be completed within 30 days of the scheduled procedure. So you cannot be 31 days. It's okay to be on the 30-day mark, but you can't be over that mark. And that history and physical has to not only include the subjective or the history for the patient, but also the objective or the actual physical assessment for the patient. Then you also have to have what's called an interval note, which is part of the history and physical. And that interval note in most places must be completed within 24 hours of the procedure. And in some hospitals, their medical staff bylaws will state that it must be completed after the admission process, which means they can't complete it in the clinic the day before. They have to wait until the patient, even if it's a day surgery patient, is admitted into the facility, and then they can go ahead and complete that interval note. That interval note, all it has to say is that there's no changes in the history and physical, and date and sign. If there are changes in the history and physical, then the provider is required to make those updated changes. The next thing is the consent. Now, consents can get really confusing. You have a documented consent, which is a paper consent that simply has the indicated procedure, including the laterality. It does have risks and benefits of the procedure, risk up to and including death, and benefits of the procedure including not having the procedure done. Those are required by Joint Commission. And then you have to have the provider or surgeon signature, you must have the patient signature, and then you have a nurse that signs that consent. They are only witnessing that that is the patient's signature. They're not witnessing whether or not informed consent was obtained. And that's where nurses can get confused. Because then typically there is a note that needs to be written in the progress notes by the provider that's called an informed consent note. And that informed consent note actually states in the record that the provider has sat down with the patient and they have actually discussed and reviewed all of those risks and benefits that were written out, and that the patient is in agreement with that. So we have a consent for the procedure. You'll also have a consent for anesthesia. So anesthesia will see that patient, and when they do, they will go through the same exact process that the surgeon did for the surgeon's procedure, only anesthesia is consenting that patient for the anesthetic. Whether that's a general anesthetic, regional anesthetic, a subcutaneous block, whatever they plan on doing, monitored anesthesia care, that is what the consent for anesthesia will read. So we have history and physical and consent. Both of those are good for that 30-day window. Consents for certain procedures based on hospital policy can be longer. They can also include range dates. So say a patient is having the same exact procedure with no changes, the consent can say procedure X, Y, and Z for a total of 13 times, not to exceed the 15th day of February 2020. So it has to be specific in the number of events and the time frame. But again, those are governed by local policy and procedure in the organization. So history and physical and consent are the two major things that we have to have. Then when you start running down the checklist, you think of all of these things and, why do we need to do it? So when I go up, I introduce myself to the patient because we are required by law to state who we are and what we are. So we are the registered nurse that is going to be taking care of you for this episode of care, whatever that is, whether it's pre-op, intra-op, post-op. I need to validate that I've got the correct patient. So I need a patient's name and date of birth. And that name and date of birth needs to match the sticker or the chart or something that I have in writing. And it also needs to match the armband that I'm either getting ready to put on the patient or that's already on the patient. So if I'm banding that patient for the first time, I'm going to confirm with them and with the record their name and date of birth, and then I'm going to band them. And then every time I come up and have an encounter, I have to ask the two patient identifiers. And it's so important for us to explain to the patient that we do this for their safety. Even though we have a relationship, I know who you are, I've talked to you 3 times this morning, I still need to do it every time I see you, and this is for your protection. And if somebody comes up and starts to talk to you and does not ask you your name and date of birth, please stop them and say, we please confirm my name and date of birth? So that is one thing that annoys our patients, and we need to really explain to them why we're doing that. Then when we start going down our list and we have sort of a head-to-toe checklist that we do you have any contact lenses? Do you wear glasses? Do you wear hearing aids? So I need to know, is there something that you need that will limit your ability to communicate with me? So can you not read without your glasses? Can you not hear me without your hearing aids? Glasses and hearing aids need to come off before surgery, and that's because glasses certainly can hurt the patient during surgery. We can break them, we can lose them. Hearing aids, we can get liquid or fluid into the hearing aids. They can break, they can short out. They're high dollar for most patients. So those need to come out. But if that patient needs them for comfort and security, until they go to sleep or anesthesia is induced, we certainly can work with the team to allow those to stay in place. But the team needs to be aware of that. Contact lenses we can't leave in at all because of the fact that we can cause corneal injury if they have a general anesthetic or even moderate sedation with contact lenses in. So those need to come out, and they need to come out by the patient. That's not something that we are going to be taking out for them because we can also cause corneal injury. Then when we ask them, do you have any artificial loose or chipped teeth? So we want to know beforehand, is there any dental damage so that we can document it and that it's not something that we caused during surgery. And then we also need to look and see if there's anything that can fall out on us during surgery. So the worst thing in the world is to do a direct laryngoscopy. So you're looking inside their mouth and throat to put their breathing tube in, and all of a sudden a tooth from poor dentation falls out and goes down their throat and into their lungs. So now we've got to get a pulmonologist typically in. We've got to come in with a bronchoscope and try to remove a tooth out of the trachea, or worse, even out of the bronchial tree. So that is a key thing that we know. Do you have any artificial loose or chipped teeth? You also have bridges. Bridges can be permanent or they can come out, and if they can come out, they need to come out. And then some dental work, like implants, are there forever, so that's fine. There's no worry about that. We just document that they are dental implants. We need to document if they have veneers. If they have veneers on their teeth, they will pop off in a heartbeat even if they just get touched by that laryngoscope blade. So we need to document whether or not they have veneers on their teeth. All of these we're going to be responsible for, the whole team, anesthesia all the way down, if we have damage to the patient. So that can lose revenue for the facility, and we are also liable in court if we have not documented that those are there and pass that information on to the correct individuals. Then we have to talk about body piercing. So do you have anything in your body that you were not born with that I need to know about? And if you do, can it come off? There are body piercings that people do not want to talk about, and I understand that. And it's certainly their prerogative and right and absolute autonomy for them to have anything they want pierced. But I need to know where that piercing is, and they need to know that they should take it off before surgery. And what I tell them is that if you have any piercings anywhere that you don't want me to know about, then please take them off, because if I have to take them off during surgery, then I don't have the proper equipment to do that, and I could cause tissue damage, and I could damage whatever it is I'm taking out. So whether it's a stud, whether it's a hoop, whether it's a bar, and whether it's in the genital area or on the chest or breasts, those are sensitive areas, and I don't think it's something that they want the nurse to be taking out for them. And, you know, there's always a risk of burn when we use electrocautery with these metal-type implants. but there's also a risk that we are going to rip them out with the sheets, that we are going to rip them out when we try to place a Foley if we leave them in. So I would rather that they're taken out and not ripped out. And if you've got a patient that you suspect has these piercings and they're not telling you, then sometimes you have to get that blunt. I would rather that you take them out and they don't get ripped out or burnt. I'm not saying to say that to every patient, but I am saying that you can suspect some patients just from the way they answer your questions that maybe you need to explore that a little bit deeper. The other thing with implants are implants that are actually inside the body. So as we have come so far within medicine, we now have implants for just about everything, from pacemakers to deep brain stimulators to intrathecal stimulators, intrathecal pain pumps, artificial joints, and those go all the way from the fingers to the wrist, to the elbows, to the shoulders, to the hips, to the knees. All of those have artificial joints that can be replaced. So we have all this electronics and hardware, and anytime we use electrocautery, we're putting a current of electricity through the patient, so it can short circuit any of that electronic equipment, so it needs to be turned off. It also changes the way that the type of electrocautery we'll use, which you'll learn in another few weeks. And so we need to make adjustments there. And then also it will help us with positioning and where we put parts of our electrosurgical unit, such as our Bovie pads, so that we're not overheating those implants and burning the patient from the inside out. Then we need to know their NPO status. That depends on their age, what type of procedure they're having done, and what facility you're in. I've seen that range from 6 hours to 12 hours. Currently in our facility, it is solid food from midnight and clear liquids for up to 2 hours prior to their surgery, which seems to be the acceptable norm now in most organizations. We also need to know if there's any cuts, scrapes, burns, bruises, or rashes anywhere on their body. So wherever we're cutting, we don't want to cut through any potential infection. So that's an easy one. But then any other of the other things that I mentioned, we don't want to have the impression that we caused those after the procedure's done. So we need to do that full skin assessment, and we're looking at them from head to toe, and we're asking them, do you have any cuts, scrapes, bruises, burns, anywhere on your body, so that we can simply document those, and we can say that there's no change whenever their surgery is completed. Some of the surgeries we do can be 6, 8, 10, 12, even up to 24 hours. And when you can have tissue injury, you can from anywhere from a grade 1 to a grade 4, you can have actual tissue loss, you can have bruising. We position people on very hard, very uncomfortable surfaces in positions that you would never dream that the body could go into. And so you can have all kinds of potential nerve injuries. So we also need to know, do they have any numbness or tingling anywhere in their extremities? So those are all things that are important, and why that we need to look at those. We need to make sure that all of their belongings are secured, unless there's something that we're going to let them take back with us. We need to make sure that they have done things to prevent infections. So many of our organizations now in their pre-op interviews are giving them CHG 4% in order to shower 2 times the night before and the morning of their surgery with Hibiclens or CHG 4%. Hibiclens does have what we call the ability to persist for up to 6 hours. So that persistence not only kills the germs at the time, it persists and it kills the germs for a period of time after that. However, the literature is unclear as to whether or not you have to use CHG or if baby shampoo even is just as effective. It's really friction and the surfactant from the soap that is going to get rid of the germs. And we're looking primarily from the skin at Staph aureus. So whether it's MRSA, methicillin-resistant Staph aureus, or just regular Staph aureus, both of those are something that all of us carry to some degree on our body. And then we also have nasal decolonization that's out there now. So many of our high-risk procedures, we're doing nasal decolonization. You can do that with 5 days of mupirocin ointment, which we know is really not effective because it's non-compliant. And also you're causing antimicrobial resistance because you're using an actual antibiotic. So what we've moved to is providone iodine nasal swabs, or a new product, which is an alcohol-based nasal application called Nosin. So either one of those can be used, and you're reducing the Staph aureus load on the body, which is primarily the reservoir is inside the nose and actually at the very tip of your nose. So you actually have to treat right up inside the tip of the nose. And then you go up into the nares itself. And that is a one-time treatment, and it can be repeated up to every 12 hours. Sometimes we have orders for that to continue until discharge from the hospital. Then we have 2% CHG wipes. And those wipes are typically done just over the incisional area or expected incisional area. Some places will do the whole body with the wipes again. They contain CHG, there's antiseptic, and they also contain emollients for the skin. And those are done in pre-op holding, and they are not the surgical prep. And we'll talk about surgical preps again at a later date. But this is all part of the pre-op process. Then after we've done all of this assessment, we're going to get an IV started so that they can start to get some rehydration because of their NPO status. They can get anti-anxiety medicine or anxiolytic medicine such as Versed, and they are prepared for anesthesia to take over their care. And then in pre-op holding, we would give a brief report to anesthesia, and we would also give a brief report to the staff nurse from the intra-op or from the OR so that they're aware of everything. But they're going to also ask 80% of the same questions that have already been asked in pre-op, which again can be frustrating to the patient. So we always need to let the patient know in advance why we're doing this. And that is to prevent patient harm, to make sure we have the correct patient, that everything has been asked and is documented correctly in the record. So pre-op and the pre-op assessment can stop a procedure. It can put a procedure on hold. I've seen it where it has caught we were planning to do an incorrect procedure, and we were able to catch that before any anesthetic was given and change the consent and make sure that everything was correct. I have seen it prevent patients from getting medications that they were allergic to. I've seen it prevent patients from getting prepped with antiseptics that they were allergic to. I have actually seen it prevent the wrong patient from getting into the incorrect operating room. So I was chief of patient safety for a large organization for several years, and I saw just heartbreaking things that would come through the operating room. And we also need to remember that when we're looking at perioperative nursing, even compared to ICU, there's no place, in my opinion, that our patient is any closer to death than in the operating room. We take over the ability for them to breathe. We take over their ability to maintain a blood pressure, to maintain a heart rate, We're doing all of that for them. We're cutting into their body. We have them positioned in ways that the body's not meant to move, and we expect to have good outcomes. And sometimes that just doesn't happen. But that's why we have to be so prepared in advance, is to protect our patients from these type of events. So as you go through and you're looking at this and you're trying to make it as realistic as you can, I just really want you to think that from a patient safety perspective, you are the first step in protecting that patient. The provider has done everything that they think is appropriate, but they're busy, they're tired, they see a tremendous amount of patients. Many of them do the same procedures on multiple patients, and things get confused and missed. That is why you're there. You are there to find these mistakes. You're a detective. You're there to have a relationship with that patient, even if it's for 10 minutes. You may only get 10 minutes with this patient, but you're there to develop that relationship, to become the detective, to search things out, and to protect that patient from injury. So I just wanted to take a few minutes today to talk with you, to let you listen to my dog bark a little bit, to let you know that this is really important stuff and where we use this in the process. And then as we go through the rest of the semester, I'll try to drop these videos in. Again, they're not for a grade. They're simply for informational purposes. But I want this to try to become a little more realistic for you. If you have any questions or comments, please feel free to send those to me. Email will work best. You can respond back to this video, but if you just send me an email, I'll be glad to respond to that and send you that answered. If you have any questions for why does this apply, why are we doing this, why is the book suggesting that we do this, I'll be glad to give you those real-world examples for why that happens. But again, I just wanted to sort of develop our relationship, let you know that yes, you do have an instructor out there. This course primarily works because of all of you working with each other. I become more of a facilitator, but I want to make sure that you have the correct information and not something that is potentially incorrect. So if you need anything, please feel free to drop that email to me. I will try to get a response back for non-urgent grading-related questions within the week. And we are going to continue through the semester, and hopefully when we're done with the semester, you'll have that overview for what is perioperative nursing. So that someday, after you get some experience in the nursing field, you may decide that this is absolutely what you want to do. Or you may decide you want to immediately try working in a surgery center and applying all of these skills. Surgery centers are so different than the hospital. So again, I want to welcome you to the class, talk to you a little bit about our preoperative assessment, and we will see you in our next module. Everybody, I hope you have a great week.